Welcome, everyone. My name is Dan Friedman, and I'm professor of neurology at the NYU Langone Comprehensive Epilepsy Center and the NYU Grossman School of Medicine. And I'm very pleased today to be joined by Dr. Sharon Chiang, who's a postdoctoral research fellow and instructor in the Division of Epilepsy at UCSF. And in today's journal club, we'll be discussing the article by Dr. Sivathambu and her colleagues entitled Preferences and User Experiences of Wearable Devices in Epilepsy, a Systemic Review and Mixed Methods Synthesis. So we're going to start out today's discussion with a case to illustrate the topic of discussion. So this is a 15-year-old boy with juvenile myoclonic epilepsy who presents with his mother for an office visit after a recent ER trip for a tonic-clonic seizure. His seizures began at the age of 13, but he continues to have tonic-clonic seizures about every 4 or 5 months, typically in the setting of poor sleep or missed medicines. His mom is really worried because when she found him on the ground after a seizure, he was breathing irregularly and he was a little bit cyanotic. She's really concerned about the risks of his unattended seizures and wants to be there by his side all the time, sleeping in the room with him. The son is concerned about his independence and privacy. And so the mom asks about, are there any devices that could help this situation for seizure detection and alerting to improve his safety? And this is a common clinical scenario where there are seizures, especially convulsive seizures, that we know put people at higher risk for morbidity and mortality, and specifically sudden unexpected death in epilepsy, but other negative consequences. And we know that being unattended or not having somebody supervise patients who are having these convulsive seizures put them at higher risk for these negative outcomes. And so there's been an interest over the past 15 years for leveraging wearable sensors to help bring seizure aid to the patient around the time of the seizure to potentially minimize the risk of seizures. At the same time, there's also been an increased recognition of the fact that many people are amnestic for their seizures and aren't able to accurately track their seizures. And physicians and patients and their caregivers don't always have the most objective data when it comes to seizure counts and to track progress in response to therapy, whether or not people are truly seizure-free. And again, there has been an interest in using wearable devices to help bring more objectivity to seizure quantification beyond seizure diaries. But what's missing in the literature is a better understanding of what patients and their families want out of these types of wearable devices, what they think they would use, factors that may affect adoption, and other potential barriers to getting these types of technologies into the hands of patients. And these technologies are already out there. There are several types of commercially available devices that are on the market in the US and Europe for seizure detection. This is just some examples. There are devices that record muscle activity from surface EMG. There are devices that record motion related to convulsive seizure activity through accelerometry, with it and without other sensors, either at the wrist in a watch form or at the arm in this type of device. And there are other types of devices that are currently under development. Some of them are apps that leverage consumer electronics, like apps that run on smart watches. Some are sensors that record EEG in a somewhat reduced form, which is the gold standard for seizure detection, and with various degrees of invasiveness, devices that stick onto the scalp versus devices that are actually implanted under the skin are all under development right now. And the question that seeks to address is really what will be most acceptable to which patients and under what circumstances.
So to address this gap, the authors, they conducted a mixed method systematic review where they synthesized data from existing studies that we have on the preferences and experiences that patients and their caregivers have with automated wearable seizure detection devices. So in this study, they applied both qualitative analysis and then thematic coding as well to the studies that they identified in their review. And they use that to identify themes that are then common across people with epilepsy and their caregivers. And another cool point is, in addition to providing a synthesis of user preferences and experiences about wearable seizure detection devices, the authors offer a good example of approaches that can be used to synthesize qualitative research in this body of literature, which may be different from the typical pooled analyses that we might employ in quantitative research.
In this study, they underwent a systematic literature review. The study was pre-registered in a database for systematic reviews. They queried multiple databases with a search term epilepsy, seizure, wearable, and non-invasive. They reviewed the English language literature, identified studies examining patient or caregiver preferences, and they reviewed the studies based on published criteria for assessing quality in qualitative studies. And at the end of their review of a relatively large number of abstracts, they came back with 22 studies that they included in the systematic review.
So from these 22 studies, they span from 2014 to 2021 across 14 different countries and a total of about 3,300 participants. The distribution of respondents among all of these 22 studies included about 58% of patients with epilepsy, about 39% caregivers, and 3% clinicians or healthcare workers. 91% of these studies were observational. The majority were observational cross-sectional studies, with the smaller percentage being observational cohort studies. And looking at what the studies looked at, whether it's preferences or experiences, the majority were looking at user preferences. So I think 73% were looking at user preferences, 23% looked at user experiences, and I believe one study looked at user preferences and experiences. And then within looking at user experiences with these wearable seizure detection devices, the majority were in inpatient settings, and then about a third were in outpatient settings, and about 15% were both inpatient and outpatient settings that were looked at together.
So amongst the themes that were discussed in these studies, the one that was a core theme was reliability of the devices, and the patients and caregivers and really did want devices that had a very high sensitivity for seizure detection and a low false alarm rate. High sensitivity, the ability to not miss any seizures, was felt to be a sensitivity of 90% or greater. The false alarm rate that many users and potential users felt was acceptable was about 1 to 2 false alarms per week. But for people who had a high seizure burden, but those with infrequent seizure had less tolerance for false alarms. Which is interesting in the literature, based on studies of devices that are on the market or in development. In their validation studies, which were typically done in epilepsy monitoring units, the sensitivity for the detection of tonic-clonic seizures ranges from about 75 to 95%. And most of the devices that are available now on the market detect about 90% of all generalized convulsive seizures if they're properly placed. And so, but the false alarm rate is of these devices is still not where this study suggests that patients and their caregivers want them to be. in at least for the marketed devices in the published data, the false alarm rates range from about 0.1 per day to 2.5 per day. So devices still have a lot of false alarm that may be a barrier to long-term use. The other thing that came out in this study was that healthcare providers, they were interested in devices that could detect seizures beyond tonic-clonic seizures, speaking to their desire for a ability to objectively quantify seizures in patients with epilepsy.
So another major theme that was identified is cost. So what about costs of these devices? And sort of unsurprisingly, they identified that pricing is a major theme as well. They saw that across their studies, between 9.6 and 38% of users have not purchased a seizure detection device due to cost, and that 67% said that they would not use a seizure detection device unless it was covered by a provider. So they also looked at price points and what people value. So they found that for a one-time cost, most participants wanted the wearable device to be less than $300. And if it would be a monthly subscription kind of package, then nearly half of people, so 43%, were willing to pay less than $20 a month. And about 18% were willing to pay more than $20 per month. Only 11% were willing to pay more than $30 a month if every seizure was detected. So it provides some good insights for pricing to be accessible to people with epilepsy. So for example, one commercial device has multiple price points for different levels of use that's currently in existence, including like a plan that's worth $10 a month to have one caregiver, a standard package that might be $20 a month, and another package that has a few more features that is $40 a month, such as unlimited caregivers or seizure report generation. So a lot of these price points seem to be consistent with devices that are currently on the market or in consideration. Another thing they looked at is device design considerations and what people are willing or interested in having. So they found that people most valued having a non-stigmatizing design that can be integrated into daily life. So smartwatches were the thing that people were most preferring, and then wristbands or wearable clothing and jewelry were also of interest. And they found that the least preferred device was sensors that would be applied to the head and face or invasive devices. To further contribute to thematic analysis, they did word frequency analysis. So they calculated a term frequency inverse document frequency statistic for single terms and then also for bigrams. So this term frequency inverse document frequency statistic, or TF-IDF, is a statistic that reflects how important the word is to a collection of documents. It basically measures the frequency of the word, which is adjusted by the number of documents that contain the word, to help adjust for the fact that some words just appear more frequently, like the word "and" will appear in every single document, for example. And on the left is shown a word cloud, which shows for the single words that they identified as being important to the collection of articles that they reviewed. So words like specificity, sensor, those were words that were very commonly coming up. And then looking at bigrams or pairs of words that came together, words like sensitivity, specificity, battery life, adverse effect, these words seem to come up commonly among the articles that they reviewed. So this provides a good example of how different quantitative techniques can be used for traditionally qualitative data to provide insights into the themes that are common across these documents.
So Sharon, in reviewing this study, what do you think are the strengths that you identified?
Well, I think this is a really cool study. It's pretty much the first synthesis we have of studies on user preferences and experiences. And as you said, we have a gap in understanding what it is that people with epilepsy and their caregivers want and prefer and have gone through in terms of the devices that are currently on the market. And having a first synthesis like this is very important for building an evidence base for informing future device development. Another major strength of this study is that most of the studies they were able to identify and synthesize were of moderate quality or higher. So they do have additional data in their paper looking at the quality of each of these studies and ranking them on individual characteristics as well, which adds to the quality of the systematic review that they did. And conversely, Dan, what do you think are the limitations of this work?
Yeah, I mean, I think that like many other literature synthesis projects, you're dealing with heterogeneous study methodologies that use different methods to measure acceptance, to ask questions, and so I think there needs to be in the future sort of a use of more standardized instruments to collect user and caregiver preference data that may be drawn from fields like marketing, consumer behavior, that can be used in studies to assess novel technologies and acceptance. The other thing that I thought was a limitation was a lot of the studies that were included were based on sort of hypothetical considerations, meaning that there weren't necessarily specific device examples. There were just descriptions of form factors, or patients or caregivers weren't presented with a particular device that is currently in existence. And their preferences may change if they were based on consumers who actually got to touch and play or even use some of these devices. Perhaps there'd be less aversion to more invasive devices if they saw other potential benefits beyond seizure detection and counting. So, for instance, there's great interest in using wearable sensors for seizure risk forecasting, that is, identifying future periods where patients may be at risk for seizures. And if there's value in that kind of information, perhaps patients would be willing to tolerate devices that are either more invasive or have more stigma because they get even greater benefit.
And so going back to our case, I guess, how would you discuss with the patient and his mother the role of devices, and what device would you suggest, and what are some of the challenges that you might anticipate?
So, this is a common scenario I often get in clinical practice, where I have family members who have witnessed a seizure, or who witnessed the aftermath of the seizure, which is very scary to the observer. They may have been told about or read about the risk of sudden death in epilepsy, and they're anxious, and they want to be able to always respond to a seizure. And so the first thing I tell them is that there are available devices that can detect certain types of seizures, and specifically tonic-clonic convulsions. And then I go and I tell them about the types of seizures people may have that these devices won't work for. I mentioned that the device is only as effective as the ability of there being somebody available to respond to the seizure. So when the alert goes off, there has to be a plan in place for who's going to respond to it, where are they, and how quickly could they arrive and provide aid or check on the patient. I also, in the cases of in these kinds of situations where there's a caregiver and a patient, they may have different goals and different levels of concern, and a lot of the efficacy of these kinds of devices really depend on whether or not people wear them. So the person who is with epilepsy has to wear the device, keep it charged, make sure it's on correctly, make sure their phone is connected to it for it to function as intended. So those are some of the limitations. And then obviously I talked to them about the out-of-pocket costs, the fact that currently these devices are seldom covered by insurance, and cost may be an issue, and I help them make a decision. I also talked to them about false alarms, and the fact that that these devices still have false alarms, that you're able to often cancel a false alarm if you're aware of it. But there may be specific situations where the patient may need to take the watch off if they're doing a vigorous exercise, if they're chopping vegetables or doing other kind of repetitive hand activities that may be misinterpreted as convulsive activities by the sensors. And every time that you take the wearable off, there's an opportunity for you to forget to put it on. And so everybody has to be invested in using such a device. And then finally, what I say is that that while these devices can detect seizures with especially convulsive seizures with pretty good sensitivity, that whether or not they could prevent SUDEP or any other negative consequences of a tonic-clonic seizure has yet to be proven, and so that evidence is still not there.
Those are all such valuable insights for those of us who are learning to counsel patients as more of these devices come on the market and become available. And so I guess what comes next, and how do you think this article will affect device development and clinical practice in the future?
I mean, I think that there are devices that are now on the market and that are almost on the market in clinical development, and I think we should collect the data on real world experiences, how patients are using them, how patients react to very specific devices, and then as I mentioned before, potentially to use standardized instruments to allow us to pool data across device types or form factors, compare pre and post use satisfaction and things like that. And what do you see? Do you see anything else as potential future directions?
No, I think all of the insights that they had in this article were just extremely useful for understanding what people want in devices, and what we have done so far, the devices that we have currently in the market, and understanding how to go forward.
Great. Well, thank you for joining me today, and it's a pleasure to have this conversation about this important paper.
Thank you.